Welcome to today's MESUD Learning Community webinar. Today we'll be hearing from Eva Quorion on medications for opioid use disorder. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before I begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. The opinions expressed by the speaker in this webinar are their own and do not represent the positions of CCSME or the state of Maine. Recording and live stream transmission of this webinar without consent is not permitted. We'll have a few minutes at the end of the presentation for questions and answers, so please hold all questions until that time and you can place them in the chat. And now I'd like to give a quick introduction to our speaker today. Dr. Quorion joined the interventional pain practice interventional pain practice after receiving her FNP certification. She then joined St. Joseph Healthcare in 2014 as a pain care provider embedded in primary care. Eva has been working with patients to help them manage their chronic pain. She has worked closely with primary care providers to improve patient safety related to chronic pain medications and other controlled substances. She now works with St. Joseph's MOUD team. And with that, I'll hand it off to Eva for our presentation. Thank you all for being here today.
Hi, thank you, Bethany. My name is Eva Quorion. We're going to talk today about medications for opioid use disorder. And so this is my contact information. So if you get the slide deck, if anybody needs to contact me with any questions or concerns, the only thing I ask is if you do reach out to me, make sure that you tell me how you know me, so that I know the context of any questions that you have. And I'm always happy to talk with anyone if they have specific questions that they don't want to bring up at the end of the talk. So here are your objectives, and you guys can read through that. I hope that everybody walks away from this talk with something new or some information to kind of chew on. And today's talk, I call this kind of a nerd talk because we talk a lot about pharmacology and how these medications work in the body, and it can feel a little bit technical, but at the end of the day, we have a person, getting this medication, and so I want to acknowledge all of the people that I work with who have use disorder and people who use drugs, and that we work very, very hard to keep them with us here on this earth. So as with any other medical treatment, we must be aware of and in pursuit of the goals of care. I like to spend a lot of time talking about goals with patients. The use of the medications for opioid use disorder is to stop or reduce the use of illicit opioid. And opioid use disorder is a condition with a high mortality, almost extreme mortality. And although the use of any opioid runs the risk of adverse effects, even death, the benefits of using these medications outweigh the risks. So I definitely want that to be one of the take-home medications. So to treat opioid use disorder, there are 3 classes of medications that we typically use. Now, there's a lot out there for some off-label medications that people use to help people detoxify from medications, and I'm really talking on the FDA approved modalities and not any of the other things that are out there that may or may not work for people, just because it's not FDA approved. So we have what's called agonist therapy, we have antagonist therapy, and then we have partial agonist therapy. Right? I told you it's nerdy, right? We're going to use all these terms. So the agonist, okay, an agonist is really the chemical version of an on switch. I'm a really visual person, so I think about all these little receptors in the brain, and they're getting a chemical attached to them that turns the receptor on. And you get the maximum desired effects, okay, from any medicine that's an agonist and on switch, but you also get the maximum side effects. So all medications that are agonists, you're running the risk of getting all the side effects, but also running getting the benefit of the maximum desired effects. And we have natural agonists that live in our body, right? We have chemicals that turn on receptors. And then we also have artificial agonists, right? The medications that we put in our bodies that are agonists. So methadone for medications for opioid use disorder, methadone is a mu agonist. Okay, so this is the on switch. So activation of the mu receptor. Okay, so that's just the name of one of our receptors. It leads to pain modulation, euphoria, respiratory depression, slowed gut motility, and of course there's more, right? The activation of that mu receptor. Mu receptors are located in the central nervous system, okay? So think brain and gut, right? That's our central nervous system. We've acknowledged in recent years that the gut actually has more neural tissue than the brain. So we have a lot of central nervous system in the gut. Also, we have receptors in the peripheral nervous system. And then also real important to know that it's in the regions of the brain associated with reward. Okay, so it's in our reward pathways. So other mu agonists above and beyond methadone are things like morphine, oxycodone, hydrocodone, hydromorphone, fentanyl, heroin, and there's others, right? There's all kinds of mu agonists out there. Sometimes they come and they go. Yeah, anyway, so there's lots of mu agonists. Pros and cons, right? And methadone as a medicine used for opioid use disorder. On the pro side of things is that there's a really easy transition from other mu agonists. So if somebody is using fentanyl or heroin, it's really easy to start methadone, right? It's kind of, bringing that on board. It doesn't really have a lot of complicating factors. The dosing can be really robust, enough to compete with a high potency street supply these days. Those of us who do this work, we've noticed in the past year or two with the fentanyl being out there that we're having some challenges having enough medication on board to compete with what the person has been taking over time. It's generally provided in clinics in conjunction with mental health counseling, right? So I think that multiple modality is really important for people seeking recovery. So some of the cons, these medications are offered in clinics, right? So that's both a pro and a con. But a person has to go to a special place to get this medication for use in addiction. Usually daily dosing. Okay, to start, the person has to go to the clinic to get the daily dose. And the clinics are often located in higher populated areas. So that poses some challenges for people who may live away from those areas. And especially in a state like Maine, right? We're pretty spread out. The methadone does not blunt the feelings, the high feelings. Okay, so methadone, sometimes people feel high or slightly high from it, but it doesn't blunt. If someone were to use drugs on top of the methadone, it doesn't blunt any of the high. Common side effects: lightheadedness, sedation, nausea, vomiting, sweating, constipation. The usual. Most of us are pretty used to the side effects of methadone. And there is more, like we have some issues sometimes with some hormonal suppression and that sort of stuff too. So this is not a comprehensive full list of possible side effects. So some serious side effects, okay, with methadone. These are the things that make you kind of, feel in your gut like, okay, we really need to respect this medication. Some serious side effects are respiratory depression, of course. QT prolongation, that's one thing that even if we're not prescribing or working in a clinic with the methadone, and we're prescribing other things, we really need to pay attention to other drugs that may prolongate the QT interval, and be mindful of that, because that methadone is a life-saving medication, right? And maybe the other diseases we're treating with QT prolonging drugs, maybe we could rethink that and minimize that risk. Serotonin syndrome, we don't often think about that as a risk of methadone, but it is. So again, you need to think about other medications that are being prescribed. I did mention earlier about adrenal insufficiency, severe hypotension in some patients, seizures in some patients, and hypoglycemia. So these are more serious effects, and of course, less frequent effects of methadone treatment. So methadone comes in a liquid and a tablet formulation, right? And a lot of us aren't really, it's not in our education to know the difference. But methadone clinics only offer liquid formulation, at least in this state. I don't know if it's different elsewhere, but in Maine for sure, it's liquid. This does provide an ease of precise dosing. When the liquid is there, you can get some, real specific milligrams, decreased risk of diversion with the liquid. But people are smart, right? There's diversion everywhere. So tablets can only be used outside of a clinic and only for pain. Okay, so that's the difference. You're not going to see somebody treated for opioid use disorder with tablets. It's only treated for pain, and it is illegal to prescribe the tablets for addiction. And I should put that, there's a little asterisk there, that the emergency departments have what's called a 72-hour rule when they're transitioning a person from the emergency department to a methadone clinic. If they're dosing somebody within the emergency department, they can do that for 72 hours, and that would likely be with tablets. And that's just to try to get somebody through a weekend and to a clinic the following days. Patient considerations for methadone, right? Like, who's a good candidate and a less of a good candidate for methadone treatment. The pros are you can start this medication without concern for recent opioid use. So somebody could have used opioids that day and can start methadone that same day. There's usually not a long wait to get into a clinic. Now, I am of the time that there used to be some longer periods to wait to get into the clinic, and these days it's I'm seeing people get into clinics very quickly, which is the way it should be. There is tighter control over dosing, and the patients initially have to have like witness dosing every day at the clinic. There's a really long half-life of methadone. Okay, so the pretty much a dose of methadone will stave off withdrawals for a good 24 hours, sometimes a little bit longer. So the cons, for patient considerations, there is a high burden of care with daily visits to the clinic. Some people, it just doesn't work for their life to go into a clinic every single day. It is difficult to earn take home. So in methadone clinics, you can get medicine that you can take home. And sometimes that starts to, they'll have somebody go into the clinic once a week and take 6 doses home with them. But it's, there's a lot of criteria that you have to make in order to earn take homes. And then you need to consider cardiac health, right? And risk of QT prolongation. What are the other medications that this person is on? And methadone might not be the number one choice. And the cons also can be the long half-life, right? So if you get negative effects, you're living with those for quite a long time in some cases. So moving on to the antagonist, okay? So the antagonist is the opposite of your agonist, right? It's the chemical off switch for the receptors on our cells. The effect is gained by stopping the activation of the receptor. The mu receptors are blocked, okay, with antagonists and will blunt any effect of an opioid if taken in the presence of an antagonist. It also blocks the effects of endogenous opioids and reduces compulsive behaviors associated with addiction. So that's why you're seeing, some antagonist therapy in even one of the newer diet medications has antagonists in there. So naltrexone is the antagonist I'm talking about. And it comes in tablet form and also a monthly long-acting injection. So the tablets are 50 milligrams. Okay, that's the only dose this comes in. And the dose for opioid use disorder is usually 50 milligrams a day, but you can dose 100 milligrams every other day or 150 milligrams every third day. And this is something new I learned from ASAM, that you can dose it this way. I had no idea. I thought it had to be every day. But this could be a game changer for somebody, right? If you say you only have to take this medication every other day or every 3 days, it might actually be a more attractive thing for somebody. Common side effects, nausea, vomiting, insomnia, and watch the liver enzymes, okay? It can create a liver enzyme increase, and this medication is used a lot for alcohol use disorder as well. And so you may have a precarious liver situation anyway. So you just have to really, you want to get baseline, and then you want to, be checking those liver enzymes at some kind of interval, depending on how stable the person is. And lower starting doses and titrating up can decrease the side effects of, if somebody has a sensitive belly, it can really help to decrease those side effects. So monthly long-acting injections, there's a 380 milligram dose of naltrexone once a month IM injection. It's given in the gluteal. This was approved in 2010. So this medication's been around pretty long time, but the patient must be 100% opioid free, as naltrexone can induce opiate withdrawal, right? It will kick the opiate off the receptors as it shuts down those mu receptors. And I will say that the name brand of the monthly long-acting injection, because there's only one, is called Vivitrol. And you hear it talked about a lot in the setting of alcohol, but it works as well as buprenorphine in the studies. It's just a difficult sales pitch, to have somebody 100% opioid free to get on this medication. So pros and cons, again, for patient considerations for naltrexone. It's a non-opioid, okay? It's not a controlled medication, which is it's a win. And a lot of patients feel that that's a huge win if they don't have to be on a controlled medication. This can be prescribed by a primary care provider. You don't really need special training to prescribe this. And you can stay on the tablets, or you may choose to get monthly injections. The monthly injections seem to be a better steady state for the person, but the tablets work for a lot of people. Helps with alcohol use. The efficacy is equal to other MOUD, and this is well covered by insurance, both the tablets and the injection. The tablets are super cheap, so if you have somebody who is uninsured, the tablets are definitely a cost savings way to go about this. Cons: must be 100% opioid free or will precipitate withdrawal. Now remember, back to the methadone, it has a long half-life, and this is where you can get really hung up with methadone, because you could induce withdrawal even many, many days after stopping methadone. And it may view this as lesser treatment Okay, so I've had some patients with opioid use disorder who definitely want opioid treatment and don't even want to consider something that's naltrexone. Even somebody who is completely opioid free. I've had a few people in the office who've been opioid free, and I'm like, oh, you're the perfect candidate for naltrexone because you're already off this stuff. But they're more familiar with buprenorphine or methadone. And so there is some stigma within people who have opioid use disorder and even providers, right? The monthly injection is pricey. Okay, I don't remember the cost, but it's not cheap. It's not something somebody would want to pay cash for. Training is needed to administer the monthly injection. It's not super complicated. I've given it many times, but it's something that you don't want to send somebody in just totally cold, right? You want to kind of spend some time with this injection because it's very viscous and you have to reconstitute it. And you most likely are going to need a prior authorization for the injection just because it's pricey, but I've never had it denied in anybody who has opioid use disorder or alcohol use disorder. So moving on to the partial agonist, right? This is a type of medication. This type of medication is still an on switch, but it has less of an effect. And it's more like, I want to say, since I'm using a light switch analogy, it's a dimmer switch, right? So partial agonists will compete for the receptor sites as well as reduce the effects of full agonists. So it's definitely a different critter, and it's kind of in that in-between state, which is kind of nifty, right? So buprenorphine is the partial agonist that we're talking about, of course. And the risks of buprenorphine, of course, are misuse. So there's risk of misuse with methadone as well. Naltrexone, I've never heard of any kind of misuse with that, but I suppose maybe, but I don't know what the benefits would be. Respiratory depression. Okay, so this is particularly when it's used in conjunction with a benzodiazepine or alcohol. And it's interesting. It's really difficult to have a fatal respiratory depression with buprenorphine all by itself. The deaths of people with buprenorphine also have other agents on board, okay, other drugs. So, that really speaks for the safety of the partial agonist. Adrenal insufficiency, hepatic events, right? So again, watch the liver, orthostatic hypotension, and precipitated withdrawal, okay, because it's that partial agonist, we can cause withdrawal. And the way that causes withdrawal is if we're using buprenorphine too close to the last dose of a full agonist medication. It kicks the agonists off the sites, causes that feeling of severe withdrawal. So buprenorphine formulations for opioid use disorder, we have some sublingual. We're really familiar with that. It often comes in buprenorphine, naloxone, the combo, films and tablets. And then there's a single agent buprenorphine tablets. There's a buccal formulation, buprenorphine, naloxone, buccal film. There's also injectable medications, and I'm going to use some name brands here because just to differentiate between the two long-acting injected buprenorphine. One of them has Atrigel, and the Atrigel is just the depot, the stuff that the medicine sits in that allows for the slow release. That one is called Sublocade. We've had that a little longer. And then there's buprenorphine extended release with either anhydrous ethanol or N-methyl pyrrolidine. However you say that, but that's the brand name Brixadi. They're both buprenorphine, but they have different agents that they use to make them slow release. And the Brixadi product has weekly or monthly injections. So sublingual buprenorphine with or without naloxone. Naloxone is an opioid blocker. It is known as the name brand Narcan, right? We hear all about Narcan, but that's naloxone. It's used to treat opioid overdoses. So won't naloxone reverse buprenorphine? Like that was one of my earliest questions when I started doing this work. Like, how can they put this both in the same med? Doesn't it counteract each other, right? Is it an on and an off switch all at the same time? And yes, it is. However, naloxone is not well absorbed when taken sublingually. Okay, so not a lot of this medicine is being absorbed. It is, however, well absorbed if you inject it. So the naloxone is only there as a deterrent for injection. Those of us working in the field will tell you that if somebody wishes to inject, they're going to inject. Okay, so it's not, I don't think it's really doing what we want it to do. And I like to say to people that, and the reason for that is that addiction doesn't make sense. Even if somebody's going to be a little bit sick when they inject something, if their addiction is telling them to inject something, they're still going to do it. So I think maybe the makers of this medicine forgot about that or didn't know that. But our patients will tell us that. So it seems, yeah, and that's kind of what I just said, that there are patients who are either going to inject their buprenorphine or don't. In speaking with them, I'm told that there's a very brief period of withdrawal that quickly goes away, and then they get the effects of the injected buprenorphine. Insurances do have a preference for the combination product. It's kind of difficult unless you have a documented allergy to the naloxone to get insurances to be agreeable to paying for it. So I tell patients that, listen, you know, we're going to use it, and I understand that they may have a preference for one reason or another, but I do try to work with them to get them the right formulation of the medicine. I have a little saying that any buprenorphine is better than no buprenorphine, especially with the deadliness of opioid use disorder. But anyway, that's the reality on that. So the risk of precipitated withdrawal, if buprenorphine is given too close to the last dose of an agonist, there's risk it will make them withdraw. This has nothing to do with a naloxone. Okay, like capitalize that in your brain, because patients and even providers think it has to do with the naloxone, that if you just take the naloxone out, you're not going to precipitate withdrawal. Not true. This has everything to do with buprenorphine's affinity for the mu receptor. Buprenorphine simply outcompetes all of these other drugs. So that's the reality of it. Okay, buprenorphine is stickier. It's going to stick to stuff better, and it's going to knock all of these other drugs off the receptors and cause the withdrawal. So providing monoproduct in the setting of, oh, this won't precipitate withdrawal is not going to work. So buprenorphine, okay? This is in the buccal, not sublingual. The brand name, again, okay, because there's only one, is Zubsolv. It's put inside the cheek and not under the tongue. It has a little better absorption than sublingual medication, has a little less bitter taste to it. It's pretty well covered by insurances, and some insurances actually prefer this product. There are 6 strengths here, and the website for this particular brand name medicine has the conversion of, if somebody is on 2 milligrams of the brand name Suboxone, the sublingual medicine, they can take 1.4 milligrams of the buccal formulation. So there is a conversion there, but the milligrams don't really feel like they line up there. But it is true, it just has better absorption than the sublingual product. So it looks like fewer milligrams. Some people attach some virtue to, you know, how many milligrams they're taking, which I try to discourage that, you know, thought process. The goal of care, again, is to minimize use of other drugs. And if we're meeting that goal, it doesn't really matter what the milligrams are that they're taking of their medicine. But it's the system that we set up. So at last, I think, a lot of people have a big interest in the new kids on the block, right? The long-acting injectables. And so we're going to go over this. We have monthly or weekly subcutaneous injections. Okay, so these go in fat tissue. There are 2 products that are FDA approved. The brand name Sublocade is manufactured by Indivior. And this was FDA approved in the US November 30th of 2017. And when we first got FDA approval in this office, I was very excited about this medication. Once I knew this was FDA approved, I then started working to get this product here and available to our patients. And it literally took me a year to get it here, which is just insane. It's not as bad as that because we've, some of us early adopters have forged some pathways to figure out how to get it in the hand in the bellies of our patients. The second product is a brand name Brixadi. It's manufactured by Braeburn, and the US approved it. The US FDA approved this on May 23rd of 23. And they had a couple of false starts. They tried to get approved earlier, but they had some manufacturing issues that needed to be fixed. And so this was available in Europe several years before it was available here in the US. So the goals, okay, decreased slash, and I put no risk of diversion, right? No risk of exploitation. Patients can't share. They're not going to overuse. They're not going to underuse. They're not going to misuse this medication, right? All of that goes away, which is for a prescriber feels really good. And also for some patients, right? These medications are never in the hands of the patients. So it doesn't get prescribed at a pharmacy. They don't go pick it up and then bring it to you for injection. The medications are stored and administered at a healthcare facility or a pharmacy. So it's not something that can get out in the public. Self-injection of this, the medication becomes a solid when it's injected. So imagine if somebody put it in a vein. It's deadly. So the goals of care, in addition to that, prolong life and achieving a steady state of the medications. So prolonging life. It's well established that there's a reduced risk of overdose death in people who are treated with any form of buprenorphine. Now, here's something that really, here's where I'm nerding out, right? But the exciting part about long-acting injectables, they do produce a mild respiratory depression, while high doses of fentanyl cause pronounced respiratory depression and apnea. And what they did in this little study that I took a snip of is that in individuals with chronic opioid use, when their buprenorphine plasma concentrations were 2 nanograms per milliliter or higher, there was a protective effect against high-dose fentanyl. Okay, what that means, and this research study, I don't know where it was done, not in the US. I can't tell from the names, but anyway, it was done outside of the country, and they had 2 groups, right? They had one group of people who did not have buprenorphine, and then they had one group of people who did have buprenorphine on board, and they were using IV, so they were very carefully titrating these medicines. So they have these people, and they had the group that got IV buprenorphine and the group that did not. And so they took both groups, and then they started giving them IV fentanyl. And they watched their respirations. Okay, this is why it was probably not going to be ever approved in the U.S. because boy, this sounds like a risky sort of research study, but absolutely brilliant. They dosed these folks with, then they used IV fentanyl, and they watched their respiratory drive. And they had a threshold, when their respirations are down to, I don't even know what number it was, 6 per minute, then we're going to resuscitate them. We're going to use Narcan on them. And so all of the people that had not received buprenorphine, they were able to depressed their respirations to the point where it was scary by a certain amount of fentanyl. And the people who had buprenorphine on board, they had a hard time reaching that respiratory depression at all. Okay, so they couldn't really, people in addiction use the term fallout. They had a really hard time of getting people to fall out when they had buprenorphine on board. And this makes me so excited because anecdotally, I have had patients, and this is not a sales pitch for these injections, but it kind of is, because I've had patients come back to me and tell me that they did the same drugs as their entire family. Everybody in the house fell out, and the patient who was on long-acting injectable buprenorphine actually Narcan their entire family. And that gives me chills, because that whole family was going to die, and that one person was awake because they had this medicine on board. Amazing stuff. And I would hear this story and I'm like, yeah, that sounds like, this hero story, but we heard it more than once. And I'm like, you know what? I'm going to believe people now that I have this research study to look at. So now I'll get off my soapbox. So steady state, okay, another goal of buprenorphine long-acting injectable, and we're going to talk specifically about Sublocade. Okay, I want you to remember that 2 nanogram number. Okay, so remember that number 2, because that seems to be the sweet spot of the serum levels of buprenorphine. Okay, and it's where people report in the studies where they reported less cravings, okay, and less withdrawal symptoms, okay, at that 2 nanograms. So that's kind of the goal of where we want to be. So if you're looking up at this this chart here, this linear, and I'm a very visual person, and so I like this graph because this is the mean buprenorphine plasma levels, okay, for people given after their first injection of Sublocade. So you see that this orange part is where they were taking sublingual buprenorphine. So you see the big spike, okay, in the serum level, and then the reduction in the serum level kind of goes to, right down. So you've got the big spike and you've got the big drop in between doses. And so day on day, your dose goes down to almost 0. And I've actually had patients say, every day I wake up feeling just terrible. And I can't wait to take my dose of medication, and then I start feeling normal again. It's because they're dropping below that too, right? So this blue here is the first injection of this product, Sublocade, the 300 milligrams. And so the nanograms went up to about, I don't know, what is that, 5, okay? And then it slowly, over a few days, okay, starts declining. But then the subsequent doses are given, and we're getting this steady state, and we're maintaining somewhere north of 2. Okay, but it's a very steady state. It has very few peaks and troughs. And so comparison, this graph down here, lower on the slide, this is the nerd part. And I see Randy's on here, and Randy's going to love this, right? Because I'm talking about C average, C max, and the C stands for concentration. And it's a pharmacology term, and something that we think that the pharmacists really think about a lot. We prescribers don't think about it nearly enough. But the transmucosal buprenorphine, okay, so I want to look at the average concentration, right? If somebody is on 8 milligrams of transmucosal buprenorphine, the average concentration is 1.37, which could be seen as subtherapeutic for some patients, right? 12 milligrams is 1.79 and 16 is 2.16. So then we're just kind of breaking the surface of 2.16. And remember, this is the average concentration. So the concentration goes higher and lower than that. And 24 milligrams is 2.84. Now on Sublocade, okay, monthly injection, you're achieving an average concentration when you're on that maintenance dose of 100 milligrams of 2.87. Look at 300 milligrams, 6.32. That's a very high level of blockade of those mu receptors. And for patients coming off the street, right, off the street, or coming to you newer, and they've been on these real high potency medications, they may need a high potency treatment as well. We can really achieve that with this particular product. So it's really exciting. So Brixadi, okay, the second brand name we have here. And I don't have a preference, and I have some more slides talking about patient selection between these two. So we have the same type of thing, right? The C average of the Brixadi products, okay? And so we have weekly products and monthly products. And so what you're going to notice about Brixadi is that we actually have the ability to achieve a lower concentration of buprenorphine in the system, which may be actually preferable for some patients. But we do definitely, we're able to achieve some higher concentrations as well. We can get to 4, 6, and even 11. Yeah, on the Brixadi monthly injections. So we're able to get those higher concentrations as well as we can, but we have a lot more choices with the Brixadi, and you can get to those lower doses on patients that maybe aren't on a higher dose of sublingual sublingual medication prior to this. So I'll get out of the pharmacist zone here, but had to address that just so you understand how these medications behave in a person's body and why somebody might come back to you and say something like, I felt like I withdrew at day 15, that they're telling you the truth. So comparisons, okay, of different factors here, the dosing, administration, adverse events, storage cost, and insurance coverage. So I have a lot of head-to-head kind of slides here, but Sublocade comes in a 300 milligram dose and a 100 milligram dose. The protocol is that the first 1 to 2 injections are loading doses of 300, and then maintenance dose is 100 milligrams. A patient is allowed, okay, so clinically you can keep them on 300 milligrams depending on their cravings, or some patients will call me and say, I'm in withdrawal, and they're usually not in a full-on withdrawal. They're usually feeling under medicated, that they just didn't have enough medicine on board, and they have some subtle symptoms of withdrawal. And the patient should be comfortable on at least 8 milligrams of a sublingual dose for 7 days prior to initiation of this product. And that's the labeling, okay? And I'll admit this to you guys, sometimes I break the rules a little bit here and there, but those are clinical decisions, and that's why we're allowed to make clinical decisions. But this is the true official view on that. Now, Brixadi has weekly dosing, okay, 8, 16, 24, and 32, and monthly dosing of 64, 96, and 128. The patient only needs to tolerate 4 milligrams of sublingual medication once in the office, okay? And if you do that, you can initiate an 8 milligram weekly injection. Okay, and you can do that once a week. And then if they're comfortable and you want to move them up to the 16 milligrams weekly and it's tolerated, then you can move them over to a monthly. Okay, you see this little graph here. There's the weekly injections, and you can do that if somebody's on a low dose, but then you can move them upward so that they can get on a monthly injection. And we don't have that sort of ability with the Sublocade. We have to get them where they need to be with the sublingual product and then move them on to Sublocade, which 6 of one, half a dozen of the other. It depends on the patient, and I have had patients who are actually injecting their Suboxone, and so it's a little bit more urgent to get them onto a monthly injection medication. And depending on their individual situation. So Brixadi dosing table, okay, this is just a little larger. It was kind of small on the other slide. So you can kind of see it gives you this nice equivalency table that really is helpful when you're moving somebody from sublingual medication. Trying to watch the time, guys. I'm a blabbermouth. sublingual medication over to the injections, and we don't quite have that with Sublocade, not exactly as precise as this. So depending on the situation. So administration of Sublocade, okay, 300 milligrams is 1.5 ml, so it's a sizable amount of medication. 100 milligrams is a half an ml. It's given with a 19 gauge, 5/8 inch needle. 19 gauge is almost a Hollywood needle. It's short, but boy, it's got some width to it because the medication is definitely viscous. The sub-Q injection is given at a 45-degree angle in the abdominal region only. Okay, this is all packaging stuff. So injection site adverse events. Okay, so this little photo up here shows you, how it's supposed to go in the subcutaneous tissue. I have seen people with this redness after an injection. It's pretty caustic stuff. Burns when it injects. I often use ways to cut down on the pain for patients. This fellow, kind enough to put his pictures out on the internet. You can see his injections. This one over here is injection number 1, little smaller. Injection number 2 is here. So on thinner patients, you're really gonna see that. This picture here, I did not put the yuckiest one I've seen. I didn't want to make everybody horrified, but from time to time, you will see a wound that pops up, and I've only seen it with this particular brand name. I haven't yet seen it with the other brand name, and there might be some reasons why, but it's definitely like, it looks like a vascular wound to me and creates a quite a crater. And the theory with this is that the injection was put too shallowly, and it's an intradermal injection is what's causing this wound. Now, in patients who are super thin, like this fellow, would be at risk for this wound, maybe more than somebody who's got a little bit more fluff on their belly, just because it would be easier to give that intradermal injection rather than the subcutaneous. So administration of Brixadi, and I might talk a little bit more about that if I still have time. 23 gauge needle, much smaller. Sub-Q injections given at a 90-degree angle. The volume of the medication you can see is way smaller. We also have more choices of injection sites, although the back of the arm is to be avoided until somebody is comfortable on the monthly injection. Okay, not the first time out, but it's nice on thinner patients to have the choice to go kind of near their glutes in order to get a place where there's a little bit more tissue for me to inject. So on my thinner patients, I actually do, if insurance will cover, I personally have a preference for the Brixadi product just because it's a smaller needle, smaller volume, more injection sites. Although I have a few people that are very, very thin getting Sublocade and very successful with that. I have personally only seen redness with Brixadi injection sites, and I couldn't find any evidence when I dove into the internet, but time will tell on that, right? So the storage, okay, Sublocade refrigerated. Once it comes out of refrigeration, it can be stored for 12 weeks. Okay, after 12 weeks, it's got to be heave-hoed, chucked. Brixadi is room temperature. Excursions are permitted, is what it says, which is not very specific. But let's say your air conditioning in your building goes out for a day or something, then that's not going to make your Brixadi no good. Okay, they're talking about the long-term storage should be within these temperatures. And really a special consideration when you're talking about your facility, right? What do you have available in your facility? Cost of Sublocade is a little north of $2,000. Okay, regardless of the dose. It does not include the cost of administration, right? EGADs, it's really pricey. Very good insurance coverage though. Brixadi, from what I could tell, is about the same. Okay, so 400 to 500 for the weekly injections and about 2K for monthly injections. And again, doesn't include the cost of administration. So not something somebody's going to pay cash for, right? And you want insurance coverage for that. Generally, insurance coverage is good, especially Medicaid is excellent. Medicare and private insurances all vary and can be a ton of work to get approved, a ton. Buy and bill is one way to obtain it. The organization buys the medication and bills insurance. It's tough to break even with this. Okay, we were not. We were doing this for a long time. We were not breaking even. And it's billed through the patient's medical benefits. White bagging, the medication is prescribed and sent to a specialty pharmacy. A PA is needed through the pharmacy benefits. Once approved and paid for, the pharmacy will arrange to deliver to the practice. Okay, and the delivery has to be the same place as the administration. Okay, you're not allowed by law to move that medication from one place to another. So the prescriber and the location must have a DEA number. So your place has to have a DEA number, and the medication also needs to be in a very tight chain of custody. Okay, you don't want oddball people signing for your medications. You've got to have things really managed. And staff members are not legally allowed to transport the medication from one office to another. So which one, right? Where you gotta figure out, where is the patient starting? Are they on higher dose buprenorphine, still not comfortable? Are they on lower dose buprenorphine and feeling properly medicated? That's consideration. What's their body habitus, right? Do they have enough subcutaneous tissue for this? Or are you going to be like, let's go over to the one with a smaller needle? And what's the patient's insurance coverage? Okay, so you need to be careful with your sales pitch. When I'm talking to somebody about, long-acting injectable, I have to be careful not to say, oh, and I want Brixadi for you, because, you have to be super careful, because the insurance might tell you which way you got to go. And you can make either one work, no matter what. You can make either one work. Phew. Okay, so that's the end of this talk. And I think we have a few minutes to take any questions. So I'm going to stop sharing so that people actually show up here.
Thank you so much for this presentation. I want to direct everyone that we are kind of a large group today, so if you do have a question, please place it in the chat, and that you will find in the chat the link for the survey today, and you'll have 1 week to complete it, and you will be able to access your certificate through the CCSME website. But if there are any questions, please place them in the chat. Can you tell us, Barbara wants to know, can you tell us what main care covers?
Yes, main care covers this. It covers everything that I talked about, except for the in sublingual buprenorphine. Main care is not going to cover the medication without naloxone. And unless there's a documented allergy, but they will cover the long-acting injectables, and all of it. But the thing with main care is that they want your justification. Okay, so you're not going to be able to just say, I want it because I want it. You need to tell main care why did you make this clinical decision? And so there's a lot of reasons to make the clinical decision, right? The patient's already been on it and I don't want to change their care. They're doing well. The patient's having problems keeping track of their medication, or the patient's experiencing, serum lows every day. They wake up and they feel terrible, and it's in the way of their recovery. So there's a lot of reasons why you would use this medication, and you just need to tell main care why you're using it. And I've never had it turned down. I have also had main care ask me a question. I've had patients who are maintaining on the higher dose of the Atrogel product, the Sublocade, maintaining on that 300 milligram dose, and main care wants to know why. The price of the drug is the same, but so I have to make sure I'm chatting with the patient each time and determining what is our next dose going to be. and why. So very good coverage, actually.
Thank you. Diane wants to know, is it accurate that Brixadi is the recommended choice in pregnancy? And what about buprenorphine versus methadone in pregnancy?
Oh, great question. I haven't looked in the most recent recommendations for pregnancy. And prior to Brixadi coming out, it was, they did not recommend Sublocade in pregnancy because it was an unknown, right? Whatever that category is, it was just not known how a baby would do with that. And it had less to do with the buprenorphine and more to do with the Atrogel. So the Brixadi product has the different kind of carrier with it that I think has more information. And I apologize, I don't have real super good information about it. However, it's more about, are you going to keep that mom in recovery or not? Right? Because relapse is particularly dangerous. So you kind of weigh the risks and benefits there. And, we were told for a long time that methadone was the better agent in pregnancy. But I don't think one is any better than the other. Okay. So the risk of a neonatal abstinence syndrome is the same, no matter what you're giving people. It's just more to figure out what's going to keep your mom in recovery and what's going to keep your mom taking care of that baby herself, right? And not having issues with moms and babies being separated or families being separated because of relapse and drug use. So I have some general answer to that question, not a great one. So I apologize for that.
Thank you so much, Dr. Quorion, for presenting for us. Thank you all for being here today, and we'll hope to see you again soon.
Thanks, everyone.